during the last year. It has been one long year, and it was just about a year ago, this past January, that we heard about a virus in China, along with some warnings. In late February, this month, about 1 year ago, we had the first confirmed death from the coronavirus in the United States in Washington State. It seems like we have social distance forever while taking other precautions, including quarantining our firefighters. We dealt with social unrest in many of our cities this past summer and saw our U.S. Capitol attacked just last month. Many of our sporting venues, theaters, restaurants, and other places we gather have been shut down. And on a more somber note, we have unfortunately lost over 480,000 of our fellow Americans, which includes over 160 firefighters and EMS providers. But as the saying goes, there's always a green light after the red light, and we are starting to see our way out of this abyss with the help of vaccinations. Today's webinar focuses on fire department vaccination programs and reimbursement around those programs. We're blessed to have three excellent speakers today to talk about this topic. First, you will hear from Chief Brian Fennessy. Chief Fennessy is the fire chief for the Orange County Fire Authority in California. Chief Fennessy has been a member of the fire service since 1978, and prior to his current position in Orange County, served as the fire chief in San Diego. After Chief Fennessy, you'll hear from Chief Tonya Hoover, who is currently serving as the United States Acting Fire Administrator. Chief Hoover is an accomplished executive with more than 20 years of management experience in both local and state government. She has successfully worked at high levels of government in developing and implementing fire protection, fire prevention, fire training, and community risk reduction programs. From 2009 to 2016, she served as the California State Fire Marshal and has also served as the superintendent of the National Fire Academy. We will also hear from Keith Turi, who serves as the Assistant Administrator of the Recovery Directorate at the Department of Homeland Security's Federal Emergency Management Agency. Keith was appointed to the Senior Executive Service in October of 2015 and previously served as the Deputy Assistant Administrator of the Recovery Directorate. He has worked in emergency management fields at the federal, state, and private sector levels for more than 15 years. There will be an opportunity for questions and answers at the end of today's webinar. So without further ado, I will now turn it over to Chief Fennessy. Chief?
Appreciate the invitation to participate, and what I'm going to share is a little bit about our experience out here, and recognizing that others have had similar and very different experiences. A little bit about the Orange County Fire Authority before I get going here. We are made up of 24 incorporated cities and the unincorporated county. My board, I've got a 26-member board, so a lot of bosses. We serve over 570 square miles, 2 million residents, 80 fire stations, and about nearly $400, or actually $500 million annual budget. Our experiences, I'm finding in talking with other fire service professionals, not just with the metropolitan agencies, but fire departments of all sizes, it appears that most of us, if not all of us, reached out to our public health agencies or health and human services agencies when we knew the vaccines would, we had an idea of when they would be arriving. And our experience here was less than optimal. Our county public health care agency director largely indicated that they didn't need any help. And if they did, they would reach out. We have routine interaction with our healthcare agency, but mostly at the EMS level, at the authority level. Whether it be through the paramedicine, QA, QI, all those things. We don't deal a lot with public health, and we kind of took them at their word that they had a plan and how they were going to deliver vaccines and those sorts of things. At the end of the day, of course, they're the lead in this area, and that this being a healthcare issue, is theirs to deal with. So, after multiple attempts of trying to get in on the ground floor and suggest that we can help and why we think we can help, Largely it was, we got it. We'll let you know if we need help. We thought we were alone here in Southern California and talking with the other fire chiefs, but it sounds like that was a something that was going on certainly statewide and perhaps even throughout the country. So when it became clear that the vaccines were going to arrive here in Orange County, and that the Tier 1A in California were going to be firefighter, paramedics, EMTs, nurses, the typical group, there really didn't appear to be any plan. So we set up, our own pod here at our headquarters. We've got a large campus. We're one of the 28 USAR task forces. So we have, incident management teams. We're large and robust enough to manage, the vaccination largely of our own and other fire departments. And so we set up a very disciplined pod with tents and nurses, and it went really, really well. The public health agency director, I'd met him a couple times in the past. He and his staff came out that Saturday morning. It was a big media event that, some of the first vaccines delivered, and he was very impressed by what he saw. About a week later, night before New Year's Eve, I get a text from him asking that I be on a call first thing New Year's Eve morning. And so I was on a call with he and the county administration officer, and they shared with me how impressed they were with how the fire service in the county had organized and delivered, administered vaccinations, and that they really would like some help, but they didn't have a lot of experience in this area. And initially, I thought he was talking about the rest of perhaps the Tier 1A folks, and in fact, he was talking about the 3.2 million people here in this county, and went on to acknowledge that they had no plan. That certainly they and staff had talked about what to do and how they could do it, but there was no plan. So we of course agreed to assist, put our best players on the field in terms of our command and general staff for our incident management team. We embedded and with them on New Year's Day on the holiday, and have been embedded and working with them ever since. We figured, what the heck, how can you do it wrong if nobody's ever done this before? So we're certainly not going to say no to assisting, but there, as you all know, there's no playbook. There was no playbook at this time. So it was literally, as they say, building the airplane as it's being flown. Dealing with public healthcare folks, great people, but very different culture, obviously, and not one that, is used to, let's just say, decision-making, very, very structured decision-making. We shared with them that we were not going to take this problem from them. This was their problem, but certainly we could provide, structure and foundation and all the things that you would expect, with an incident, the planning P and all the things, all the ICS 700, 800 that they'd taken before they were actually going to see in play. Yeah, but they had to give us the latitude to make the kind of decisions we needed to for the operation to be successful. And they put a timeline out that they hope to have all 3.2 million, both doses, if there were 2 doses, done by July 4th. We told them it was pretty ambitious. They even had a title for it. It was Operation Independence, and they'd already had the title before they had the plan. So again, great people, but when you're embedding, with an organization like public health, there certainly were a lot of issues. We knew we needed to grow beyond just the, our service pods. The county had bought some software that, quite frankly, was their only solution. It did not initially work very well when we had to keep going back to paper. And one of the challenges we have right now, what we're hearing, is that the state may be requiring us to use some other software. We're hoping that the current software will integrate with it, but it was not very functional, and regrettably, it was, all the eggs were in that basket. We certainly got past that. Again, expanding beyond the fire department sites. They work well, they're efficient, effective, but not built for the general population. And we needed to, start to expand and develop these what we were calling super pods. We've got 2 set up in the county now, one up at Disneyland in the giant parking lot they have up there, and one at a local university, and 2 more that we're about to put in service. The underserved were certainly a group that were not being vaccinated at the rate we all would have liked. So we've got smaller pods set up to address some of those areas within the county that are underserved. We've got a homeless population that is a part of that. We're taking care of them. And of course, the skilled nursing facilities, we've got groups that are going out and addressing those. One of the interesting things we found with the cities is that, and many of us are old enough to, been working past 9/11, and all the grants that were made available to at the time, and they were nerve agents and a number of things that were the threat. A lot of money was provided by FEMA to develop these pods. Every city had one, everybody had a plan, and there's been, what we have found is there's been such turnover at the city levels that many of the city managers, administrators, elected officials had no idea that A, there was a plan, and B, where that plan might be located. And so when the county shared with them that, we're the county, but you're a city, and you folks need to be involved in this, dust off your pod plans. And that was a big aha moment for many of them. Many of them expected the county just to pay for it all and take care of them. Many of them, again, had no idea that there was a pod plan, or that they were expected to have pods within their own agencies. When we started staffing the super pods, it was with a lot of fire department personnel, but the real challenge for us and the other metropolitan fire departments here in California were that we were seeing, a lot of people on our department, our firefighters were sick. We had at one point, I think here internally, we had 100+ firefighters that were out sick, and probably another 40 or 50 that were awaiting tests. So, our big challenge was making sure that our fire stations were staffed. And we got back to forcing people like we would perhaps during wildland fire season, when we need to make sure those stations are filled. And so we didn't have a lot of extra paramedics, firefighter paramedics or firefighter EMTs to provide. And that caused a little bit of friction between us and the county, because they just assumed that the firefighters could do it all. And just certainly wasn't the case. So I'll get this slide in just a moment here, but was an aha moment for them. As the vaccines of most all the firefighters, at least those that have chosen to participate, have gotten their second vaccines, we've seen that number of out sick due to COVID and those waiting results dramatically decline, as has most fire departments. We assumed that would make available more firefighters to volunteer, perhaps being paid on an overtime basis to raise their hands, and it's not been as large as perhaps we would have hoped. Much of the staffing here for the super pods is based on volunteerism, and we've had a number of the Association for Dental Hygienists, the pharmacist groups, the nurses, just these large organizations that have volunteered to step up and provide both vaccinators and folks to check people in. And what we're finding is people are pretty enthusiastic about that until maybe about the second or third day, when they become a little less enthusiastic about the work, and many don't show up the next day when you expect them to, and we will backfill with firefighters or anything else we can, or the number of clinics within the super pod will decrease, and perhaps, unfortunately, not everybody in line will get their vaccination. but it literally is a day-to-day challenge and change. Some of it politics, driving who gets what. We have not, unlike our neighbor to the north, Los Angeles County, had any issues with the inventory of vaccines, but that's largely because our throughput has not been what it is now. We're now getting about 12 to 13,000 vaccines in arms a day. With the super pod, that's going to grow. North of us, their throughput is greater, and thus they are having inventory issues. We expect that if it's not, we keep hearing that it's going to get better. We hope it does, because we want to get to a point where we're delivering 25 to 30,000 vaccines a day. What's been really interesting is the extra vaccines. When you've got we've got 200 people in each super pod each day, kind of waiting on the sidelines to see what's left in leftovers. And we've had, we're using a division chief to manage each of these super pods, and that individual literally goes into the crowd and tries to identify who those are that are 75 years or older, 65 years or older. And if there's 20 extra vaccines, he's out there identifying those people and leading them into the tent. We've had to use surge teams. And I talk about the huge volunteering effort and some of those folks not showing up. We've got 4 teams that when people don't show up, they can surge, go in and plug, whether it's delivering the vaccines, administering, whether they're checking folks, parking people, but we've had to have people on the sidelines ready to do that. Again, with the workforce being different every day, it's just provided a number of different challenges. Supply chain, again, I talked a little bit about the inventory. We are keeping up right now, but again, once our throughput, and every day it gets more and more, we expect that to be a challenge. So we're hoping that the timing of additional vaccines ending up here will be about the time we're hitting stride. The reimbursement of expenses, we knew early on that was going to be important. And so we and most others have been keeping a very accurate log of what we've expended. We're really pleased that, with FEMA distributing the information that they're, be this 100% cost share. I mean, that is, all of us are obviously expending a lot of unbudgeted budget, and it's going to be a challenge for us and the many cities that continue to they're just challenged. That's all I'll say. With 24 cities, I mean, most all of them are in fiscal hardship, and so this was welcome news, and we appreciate FEMA stepping up as they have. Tracking, talked about that, separating. One of the things we've learned, and not just recently, but from just our work with the USAR task forces, is you got to communicate often with FEMA. And I know FEMA's going to be speaking here soon, and they encourage that. And as much as they encourage it, the agencies and organizations I find complain the most are the ones that don't communicate early enough or often enough with FEMA. So when FEMA does reach out and they do tell you, hey, get in touch with us, they mean it. And our experience is they've been very, very helpful, and they've been quick at turning around answers for us. Before I jump over to a strategic planning document, I just want to share that, for us, I think in the fire service, certainly here in California, certainly in Southern California, one of the COVID benefits, if there are any, is just the level of exposure that the fire service has gotten here in California and again locally. The fire service obviously has a great reputation. We're trusted, and we're out there all the time, every day. But quite frankly, our model, of in the bat cave in the station, we come out when there's a response, or we're shopping or we're running. We're not out as much as and in the public view as often as perhaps I have thought all these years. And even when I've got, 20, 30 firefighters among, the 200, 300, these super pods, then they're noticed. And the number of email, the number of letters and feedback that we've gotten from the community about seeing their firefighters out there has been astounding. And what the message is mostly is how nice they were treated, with the dignity. On the hot days, they were given water, they were given seats. And I kind of think to myself, well, of course it's that way. It's always that way. We've always been that way. But man, the exposure has been outstanding. The fire service is front and center in this. And I'm proud to be a firefighter or part of all this. It's tragic that we've had to go through this crisis, and this is again what it's taken. I think the last time it's been like this was perhaps 9/11, but this is an opportunity once again for the fire service to shine. I won't spend a lot of time. I've only got a couple more minutes before I hand it over, but I did want to share that here in Orange County, we did put early on, we recognized this was going to go many, many months. We put a COVID strategic plan together, and we included, all levels of the organization. And as most the typical ICS planning process is focused on the next day, the next week. We really kind of looked at it as much like the military does, as a campaign operation. We knew it was going to be too complex, that we needed to take a mission-driven approach and think outside the box, well down the road. The strategic plan that we put together is evolving almost daily. It's robust. It's got different lines of effort. We define, decision space for all levels of the organization. Again, I won't go into too much details. I'm coming up, but the very last slide, there's an address, a web address. Feel free to, all of the information is available at this website. If you're interested in knowing more, I know I provided the IAFC with the other documents. You can also email or get in touch with me, and I'll send you everything we got. And it's really helped this organization immensely, having that look at it. It's never too late to start. So I will, I think I'm at the end of my time here. So I'd like to turn it over to my friend, Chief Tonya Hoover, the interim U.S. Fire Administrator. Chief Hoover.
Thank you very much, Chief Fennessy. It's great to be with everyone this afternoon. So with the theme of brevity, I'm going to keep my comments short. I do want to focus on thanking the IAFC for hosting this important webinar and for your continued partnership with the United States Fire Administration. I also want to thank our partner at FEMA Recovery, Mr. Turi, for being part of this webinar and sharing his insight and information that will be of great benefit to America's fire and emergency medical services. Thank you very much, Keith. In the theme of our past fire administrator, Chief Keith Bryant, we at the United States Fire Administration are committed to keeping our stakeholders connected to information available through FEMA and DHS, which means continuing webinars such as those of last year and of today. We've all heard President Biden speak on the critical nature of the task at hand, getting vaccinations distributed and into arms. Everyone has a role to play in increasing vaccinations. This webinar provides insight into the important role the American Fire Service holds in success and ensuring that information is provided for federal reimbursement for eligible emergency work projects to ensure resources are available to support the vaccination distribution and administration. So now, without further delay, I'd like to turn the remainder of the program over to Keith Turi, as was mentioned earlier, our Assistant Administrator for FEMA Recovery. So Keith, they are all yours.
Great, thank you very much, and thanks everybody for the time and the opportunity to talk to you today. First of all, just say I appreciate the opportunity to hear discussions about the Orange County experience, and I think that there are a number of things I can touch on today that'll cover some of those same points from the overarching FEMA perspective. So I have a number of slides I'm going to walk through. I'll tell you, I'm not going to spend a lot of time on each of these slides. My hope is that you'll have them for your reference, but I'm going to walk through them and try to give you a little bit of framework of what FEMA is doing in the vaccine world, a little bit about our overarching COVID response, because as you look for the potential for reimbursement for vaccines, it also very much connects to our overarching effort, and try to give you some insights around that, and then happy, of course, to answer any questions. So our agenda there, you can see that. I'm going to jump to the next slide. So first, most importantly, I think, as was mentioned, we've been in this since February, March of last year. And FEMA has been fully committed to the COVID-19 response on a number of different fronts, including supporting vaccine planning and coordination with our other partners on planning for the distribution and administration of the vaccine. With that said, when President Biden came in and issued some direction, it really kind of doubled down on the federal role in coordinating and helping all levels of government ensure that the vaccine gets distributed as efficiently and effectively as possible. And of course, that included an increased effort from FEMA. So we've been working for the last number of weeks towards those goals of ensuring that there's 100 million shots in arms in the first 100 days, and also working aggressively towards ensuring that a number of sites are supported or federally supported. Planning had been going on for a while. We were part of that planning. So really not a new effort, but just an extra emphasis on the role the federal government can play in that support. And that's not just FEMA, of course. We have critical partners, CDC, DOD, and others, many others, that are helping support us in that effort overall. Next slide, please. So big picture, before we get into the reimbursement portion, just what FEMA is doing in terms of vaccine distribution. One, we are coordinating. We have our National Response Coordination Center here in DC that has stood up. We also have regional response centers at each of our 10 regions that are fully activated and working to support the coordination around the distribution of the vaccine. Part of our goal is supporting state and local efforts and like the ones that we just heard about in getting the vaccine distributed. There's a number of different ways that we can do that. One is funding, and that's going to be the bulk of my time today. I'm going to talk to you about the funding aspect of this, and that's through our public assistance program. But it's also through coordination and the identification of support that can be provided from a number of different entities. And then also directly providing materials, staffing, and other direct support to the setup of community vaccination centers and the execution of those centers. And so we have staff that are deployed to a number of sites around the country. We have material that we are providing directly to a number of sites around the country. And so funding is the big thing that we're doing, but we have a larger role there as well. The other thing I'll add is, in addition to supporting what the states and the local governments were already planning for, we have been, in the last number of weeks, doubling down on providing the opportunity for coordinated but primarily federally supported sites. And so we've got a couple pilots that are working towards opening ideally next week in California, and in addition to other sites to come from there that will be with our partners from DoD. In addition to the state and local managed sites, we'll be looking to set those up. We've got a playbook that we've put out on our website. It just essentially shows the models that we're going to be using for those operations. It's got 5 different types of community vaccination centers, and they range from what you might consider a mega center all the way down to a smaller, more compact center. We've got mobile options that are included. And in fact, we're already supporting 6 mobile vaccination centers right now, among many others. And then, and also the difference between drive-through centers or walk-up centers. So a lot of planning and execution that's been going on, and we are working hard, but still a lot of work to go to get all those up and operational. Next slide, please. So just a couple points. When the $60 billion there you see, that's our overarching COVID response, not just vaccines, I'll give you the vaccine number in just a minute, but a lot of funding going from FEMA for the COVID-19 response. To date, we have 326 federally supported vaccination centers. And just for clarity, that means a vaccination center that is receiving one of the things on the previous slide, either staffing, funding, materials from us, from the federal government, and those that have are up and operational, and those that have done so since January 20th in terms of additional help that's been provided. I want to make sure that we're not counting federal sites as those that were already up and running and haven't been executed based on this increased effort that we put forward. So since last number of weeks, 326 sites, we expect that to grow significantly. Another point on this slide, I just want to touch on another area of focus for us and for everyone involved in the vaccine administration distribution is the equitable distribution of the vaccine. And so we know that many of the state and local governments are working hard to collect as much information as they can about the distribution so that we can all look holistically and evaluate how it's being distributed. We can all make sure that we're considering those populations that may have access issues or may have additional challenges. And so we're hard to make sure that happens. So equity is a big part of this. We're moving quickly, we're moving fast, we're trying to do it right and do it smart as well. And so that's a big part of it. But of course, that is a team effort, all levels of government, everyone involved working together. It's not just a FEMA role. Next slide. This gives you the funding so far to date, $3.1 billion, and actually all of that has been awarded since January 20th. So we've got a lot of work that's been done. Eligibility was established earlier, but just a lot of extra effort put on to get those dollars out the door in the last number of weeks. And so 49 states that have either have projects that are approved for that 3.1 or ones that are in process that we are working towards approving, and that should be a map of the U.S. I'm not sure why it's showing up that way, but those are our stats on our funding to date. Next slide, please. And so I'm going to give you a little feedback. That's our big picture posture. Now I want to just talk a little more specifically about the program, our public assistance program that is the primary source of funding for vaccine distribution administration. And this is actually, you'll see as I walk through this quickly, this is the primary program for providing reimbursement and funding for COVID-19 response overall. There's a number of things that we're doing, but it's also where the focus of this session on vaccine costs is where it falls into. So if you're not familiar with it, and as was mentioned, many communities that are executing this vaccine distribution and COVID-19 response overall, we work with on a regular basis, but many of them we don't. And one interesting stat is, considering the scope and scale of COVID-19, we expect that we're going to have more applicants for assistance here from COVID-19 than we had from Hurricane Katrina, Rita, Wilma, Sandy, Harvey, Irma, Maria, and Gustav and Ike. And so put all those disasters together and look at the number of applicants we have, we're going to have more here from COVID-19. And it makes sense. You get a nationwide impact, nationwide emergency. But it's a pretty significant effort for us and of course for all the partners. Some highlights there for the program on what the program does on a normal basis, non-COVID public assistance. And again, I'm not going to go through all these points, but you'll have these slides for your reference. Next slide, please. And this is specific to what has been done for COVID-19. So March 13th, 2020, President declares a nationwide emergency. That starts the ball rolling for FEMA public assistance funding to be provided. Since then, we've had major disaster declarations in every state and territory, and we have 101 emergency declarations, including 89 tribes. So essentially every entity in the country that would be an eligible applicant, and I'll talk about that in a minute, are eligible for receiving assistance from FEMA. The funding that's been authorized is only those emergency protective measures. So as like you saw, and you can imagine, our traditional program covers a much wider scope of activities. We are funding a lot of permanent restoration, roads, bridges, schools, et cetera, that are damaged from a traditional disaster. That, of course, isn't applicable. So the only form of assistance authorized is the Category B emergency protective measures, and that is for activities to reduce the risk from immediate threats to life and safety. So that is what we're focused on. We did push out a number of specific policies. It's the COVID environment and the circumstances of the pandemic, of course, different than what we're normally facing. We had a lot of work to do to try to apply those standard authorities to this scenario. And so we've worked to do that with providing additional guidance. We've also done some process streamlining that I'll talk to you about in just a minute. Next slide, please. So just a couple highlights, not vaccine related, but since I'm here talking about the program, other things that we approach specific policies out for: purchase and distribution of food and commodities, medical care. That's the big area of our focus has been. That's been increased medical capacity, medical staffing, equipment needed, alternate care sites has been a big focus on it. And then non-congregate sheltering has been a big area as well. And that's for allowing for those that either can't quarantine, can't isolate, high risk, can't otherwise socially distance, the availability of funding for non-congregate sheltering at the direction of local health officials. It's not a strict policy from a FEMA perspective. We needed to defer to the local health community and the federal health guidelines for them to do what they thought was best. And so that's really what's driving a lot of our policies. And then we just got a reference there, our policy from September 1st is what's currently in effect and was applied to the majority of our funding under this program. Next slide. So I'm just going to touch on these. You heard the chief mention this earlier in his presentation. You did see two presidential memorandums that have been issued since January 20th. One's on the 21st and one on the 2nd. You can read the text. The practical impact of this is that all funding for public assistance will be 100% funded from the beginning of the pandemic, from January 20th, 2020. That's when our incident period started. It's when the public health emergency was declared, and it goes all the way until September 30th, 2021. So that will all be at 100%. Previously was at 75% federal funding, 25% local, and so that provides additional resources, as you heard about. One thing that we are also doing is providing flexibility on the source of funding. And so there are many other resources available from the federal government. Treasury has funding, HHS has funding, HUD has funding, Department of Education has funding. And so as our cost shares are adjusted, even if something had been funded by another agency previously, localities, states can make adjustments to that to repurpose those other funds and use 100% of our funding. We won't pay for the same thing twice. Obviously, if we will be asking for certification that the federal government's only paying for each cost item at once, but there is flexibility that's allowed for that kind of adjustments that we made based on this change in our federal cost share. And the last thing I'll mention there is just that we have a additional eligibility for opening and operating costs. And so what we were not paying for previously was the day-to-day costs of screening and PPE and social distance measures, plexiglass, et cetera, for opening certain facilities. That is eligible now based on this January 21st presidential memo, and we are working on a policy to get that out. So more to come on that point. Next slide, please. Just reference there, if you were looking for resources on our guidance, both coronavirus related and otherwise, you can find at those links. Next slide, please. And next slide. So just vaccine specific. So how are we supporting it from a funding perspective? I'll say this slide gives you the highlights of the things vaccine related that we're supporting. That includes PPE, facility costs, transportation, medical support staff. Our intention on our vaccine distribution administration policy is to be broad. So in general, if a cost is required to distribute and administer the vaccine, if it's consistent with the overarching federal strategy, and so what was formerly known as Operation Warp Speed, it's now called the Operation, that planning effort that's been going on, the vaccine that's being obtained through that process, if it's coordinated with that overarching plan, then those costs are generally going to be eligible. And it's not just FEMA has funding, HHS has money as well, and CDC has money that they're pushing out for this, but recognizing the scope of the need, we are also providing assistance. So this gives you a list of the things that are eligible. But in general, if it's a required cost and if it's reasonably expected to be needed, then it's going to be an eligible expense. And so your staffing costs, your equipment costs, your facilities, transportation, et cetera, those are eligible. I'll talk a little more about those in just a minute. Next slide. Things to be considered. I talked about this just a minute ago, but just reasonable and allowable. Right? So that's always a little bit a classic term for federal grants. The cost must be allowable, must be reasonable, they must be necessary. And we're talking about things where what a prudent person would do. So we have a couple examples on the slide of things that are not wouldn't be considered eligible if you need PPE for a 6,000 per day site, but you're only doing 1,000. Those are the kind of things we look for to make sure that the plans sync up and that the costs that you are asking for are fit in within your larger plan. They fit in within the outcomes that you're driving towards, but otherwise, generally eligible. The second bullet on that this slide is one I'll just draw your attention to is the state emergency management offices. So all of our funding is coordinated through the state emergency management offices. Generally, they're all grants to the state level, and then they are sub-granted down to other entities. And so particularly when it comes to vaccine distribution, but really for all of the COVID-19 expenses, it's really important to stay synced up with state emergency management offices as what their plan is. Many states are pursuing state level funding from FEMA. And so we're working with the state, looking at what their overarching costs might be and awarding funding to the state at the state level. It doesn't mean that it can't be obviously sub-awarded to a local government and that local government costs won't be eligible. It's just an approach that many states are taking to kind of have a central point for coordination of that funding amongst their efforts, because obviously a lot going on statewide. And also administratively to do that in a pinch, we're trying to move quickly than individual projects for each locality. We are doing individual local projects that are allowable, just a strategy that many states are taking. So again, I would encourage you to touch base with those state EM folks and make sure you're synced up with them. The last bullet kind of hits what I've been hitting on here is that if you don't see something explicitly on the list of eligible activities, particularly vaccine related, and you're wondering, work with the state, get in touch with our regional offices, and we'll be able to provide some clarity in that regard. But our goal is to support you and support those activities and leaning forward in getting this vaccine out and available as quickly and efficiently as possible. Next slide. So next slide, I'm just going to go through a couple points on the delivery process. So one thing we've had to do, I talked a little bit about streamlining the process earlier. Typically how we'll do business after a disaster, wildfire, hurricane, we will have our staff, they'll set up a joint field office, they'll come get assigned to individual applicants. You'll have someone from FEMA that's assigned to you to come work with you on your reimbursement. Obviously that wasn't going to be possible in a COVID-19 environment when we have the number of applicants that I referenced earlier. So what we've done is set up a direct application process, and this flow chart gives you a little bit of the way in which that works. You can see the website there, grantee.fema.gov, is for those of you that have not yet submitted requests, that you can go and submit those requests. They'll get filtered through the state entity, and they'll be able to help shepherd those through, and we'll conduct that review. So what normally would happen would be a FEMA staff would help you compile your list of damages, your requirements. You're going to now put those in a direct application, send them on. You'll get feedback on data elements that are missing or things that are required, but trying to really streamline that process, get things moving quickly, but also be able to manage the workload for everybody nationwide. Next slide, please. So yeah, just a little highlights here on what you need to include generally for these applications, and we have tried to streamline this with a standard application that is specific to COVID-19, so it'll ask you the right questions for you to fill in, but you need what you'd expect: a description of activities, when, where, by whom, an itemized summary of how much, and what specifically kind of the cost category was. What was a contract, what was labor, what was equipment, etc. And so there's more information on the website link there you can find about how to provide that documentation, but that's some of the basic information that is required. Next slide, please. Just some best practices, some things to highlight for you. We have Federal acquisition requirements. I think you're all familiar with those. Obviously, you have to, when you're on a federal grant, you have to follow federal procurement. Now, one good thing in the context of meeting the requirements of the pandemic is that we do have the ability to use what we call exigent emergency circumstances. And so that's when there is a necessary to move quickly to save lives, protect property, public health, which is absolutely the scenario that we're in now with a public health emergency. There are opportunities to streamline that. We've put a fact sheet out, which you can also find on our website, on how you can navigate those requirements. Essentially, in short, it is about documenting the rationale and the reasons why you didn't have time to do some of the other normally required procurement activities, and that's all laid out in that fact sheet. I talked about the necessary documentation. I would just suggest that you take the extra time to read carefully what's required when you submit for reimbursement. The more information you provide up front, the faster we can get that turned around. If we have things that are missing, we'll send you a request for information for you to submit that back. Of course, that is one of the major factors when we look about how fast dollars move. Whether we had to send a request for information or not will be a big factor in the timing of getting that reimbursement. So. Not so applicable for vaccines really in this case, but for other activities that demonstrate the legal responsibility. And so our funding is only available for those applicants that are legally responsible to take a certain action. So, for example, in the vaccine world, a private nonprofit organization that might partner with a state government, does not necessarily have the responsibility to save and protect lives, but the government entity does. And so the government entity would be the legally responsible applicant, and they can partner with private nonprofit or other applicable entities to execute that work. So legal responsibility is a key part of making sure that we have the appropriate actions for the appropriate applicants. And then lastly, the duplication of benefits. In a traditional disaster relief setting for our program, normally non-COVID-19, we don't fund things that are under the authority of another agency. So for example, if the Corps of Engineers, which they do, has funding for levee repair, then except for a few limited circumstances, FEMA doesn't pay for levee repair. Our disaster assistance is supplemental to the other federal funding that's out there. We are not taking that approach for COVID-19. It's one of the things we've done differently. There are many funding sources that have been created for COVID-19 response. Many other agencies have money. We are not saying that if another agency can pay for something, then we won't pay for it. Well, essentially, what we're saying is we won't pay for the same activity that another agency pays for. So you can't get reimbursed for the same contract from one agency for another. Common sense and pretty straightforward, but that's how we're handling the duplication of benefits issue that we're normally facing. Next slide. Just real quick, next slide after that, just give you some resources on where you can get information. So recipients, you can find the second bullet there gives you where your state emergency management offices are. I'm sure most of you are in contact with those folks, but if you need the resource, you can go to our website and you can identify where they are. Also, you have a vaccine support page. We have a support page specific to vaccines. Earlier in the presentation, I gave you the resource pages for our policy. You can find that, but here's where you can get exactly what FEMA is doing on the vaccine front. And I think that's the last slide. Next slide, please. Yep, that's it. So I know it's a lot of information. I wanted to give you a slide deck that you could use for reference. You can use those points and links to find what you're looking for, but appreciate the time to talk to you today. And as was said earlier, FEMA is here to help. We're here to support. We've got a lot of resources in our regional offices that are ready and willing to answer your questions and help you get what you need. So don't be afraid to reach out. Thanks.
All right. Well, thank you, Keith. And thank you, Chief Fennessy and Chief Hoover. Before anybody goes, we do have some questions that have come in. And so the first question goes to you, Chief Fennessy. And the question is, are you using standard incident action plan documents? And if so, how did you get the health department to buy in?
Great questions. Yes, we are. We're operating just like we would any other incident. We're not calling it an IAP, we're calling it an EAP, but when you open it up, it looks just like an IAP. And they are running 24-hour operational periods. And I'd be willing to send you the most recent copy or make it available to the IFC so you can kind of take a look at it. But when you look at it, it really reads like, a unified command document. Well, you'll see a fire department IC, you'll also see a public health agency IC, the plans chief. And so that piece certainly, there was a lot of friction at first, even though it's their emergency or they're the lead. There are times where we had to say, no, we're not, this is how it's going to have to go if you want it to work. And they've had to acquiesce. And with that obviously comes friction. Now we're 6 weeks into it. Most of that's all gone. They understand certainly the strengths of, the fire service and how we solve problems. And the follow-up was, I'm sorry, Chief Ludwig, what was the second part of that?
And how did you get the health department to buy in?
Well, I think they really didn't have any choice. I mean, quite frankly, they appealed to us and we were their only option. I mean, absent, had we said no, there was no plan. I mean, so it's unfortunate that they waited as long as they did. It still ended up probably being the first county in California where the public agency appealed to their fire department to help. The others quickly followed, but as I understand it, even within this state, there are still some counties in this state where the public health agency are not working with the fire service. And in each and every case that I've heard, once the fire service was involved, things tended to move along very, very quickly. So regrettably, they really didn't have any other option. They needed us more than we needed them. How's that?
Yeah, and I would agree. It makes sense. I mean, we're used to dealing with challenges and problems and coming up with solutions and fixing it before we return back to the station. So I hope those other health departments out there, turn to their fire departments, because there's only one reason why there's no more smallpox and no more polio. It's because we have vaccinated our ways out of those. So I got another question for you, Brian. Were the EMTs and paramedics of the fire department operating the pod the only members permitted to administer the vaccine?
Initially, our nurses, we've got several nurses, and I get that's something not everybody has. They were the ones actually putting the needles in the arms, and the other staff were actually loading the syringes. As it ends up, the county relaxed their policies on who could actually administer the vaccines, and so now EMTs can administer them, as well as our paramedics. And interestingly enough, it's the other way around. The nurses now have to be the ones to fill the syringes, and it's the others that are administering the vaccine. And since the vaccines as a whole fall under the license of one of the county's doctors, she really has the ability to dictate, how that all goes. So even though we've demonstrated there could be some efficiencies of it being done differently, equating into more needles in arms, end of the day, the doctor's license, they have some level of control, but it's been evolving.
Okay. So this is a general question, and any of you are welcome to answer it. It's kind of a general question. How can we manage or react to fire structural design to comply with the current trends of our organizational network and the new face of how supply chain has changed? You want me to read that again? How can we manage or react to fire structural design to comply with the current trends on our organizations? I'm sorry, let me read it again. How can we manage or react to fire structural design to comply with the current trends in our organizational network and the new face of how supply chain has changed?
Chief,
I'm like you. I'm trying to sort through this question to understand the intent.
Is there an easier way to say that for some of us knuckle draggers that are still out there? I think I understand, but I don't want to.
Yeah, and And I fall into that latter category you just described. So I'm trying to discern the question here also. And how can we manage or react to fire structural design to comply with the current trends in our organizational network and the new face of how supply chain has changed? I'm having trouble understanding the intent of the question also. And so let's think about that and kind of move on. This might be also for you, Brian. What is the intent-based planning and how is it better than ICS?
All right, there you go. Well, it's not that there's ICS and intent-based planning, you know, are different things. I think when you go to, you know, what we identify, I know it's I hope you can go to, whoever asked the question will go to the website we provided, but we identify lines of effort, again, for the organization, and you know, some of those are political, some of those are infrastructure. I'll give you an example. So, you know, one of the lines of effort for us here organizationally is succession. Well, when I normally think of succession, I think of preparing, you know, folks to replace all of us, right, at some level. Well, when we talk about succession in the COVID strategic plan, it has more to do with, you know, we look at our IMT. I've got 2 or 3, you know, qualified plan section chiefs. Well, that's pretty good when you're on a wildland fire or something and you need to switch them out every 14 or 21 days or whatever it may be. But when there is no end in sight, 3 plan section chiefs isn't enough. And so it's causing us to look within and go, look at it. You know, this is not normal anymore. We need to build, we need to have a deeper bench. And what's it going to take to do that? And it's just a very different approach. And like I say, that there is no conflict between the two. But I would encourage folks to take a look at that or contact me and I can share it with them. But it's you know, my experience with strategic plans back in the day, I think we've all dealt with the 4 or 5 year strategic plan, and we're told it would never sit on the shelf, and we would, what, 2 or 3 years later, you know, it was sitting on that shelf. The intent-based strategic planning allows you to pivot very quickly, day to day, hour to hour, if you need to address those changes that occur over the life of any strategic plan. And there are individuals at all levels of the organization that are required and held accountable to inputting those things. So literally, you go there, it's a snapshot of where we are today, where we're going, what we've accomplished, you know, through each of those lines of effort. So it's a lot. So I'd encourage folks to take a look at that if you have the chance.
Wonderful. Keith, I think this might be applicable to you here. So it says, if the local fire department provides paid paramedics to the county health department to give the vaccinations, can the fire department apply for the PA?
So yeah, the costs can be covered regarding regardless of what entity it is. What I would suggest you do is coordinate with the county health department, because you have to make sure we're going to look to see that all those requests are appropriate. It might be more efficient for one entity to submit and then deal with the funding between the two. But at the end of the day, whether the fire department applies or whether the local county health official applies, they're eligible costs, and we'll find a way to work through the appropriate way for reimbursement there. I would say documentation will be important to make sure that you just show that agreement and that request and that the requirement that you were responding to. But yeah, it can be the fire department is an eligible applicant to apply for it. And just while I have the mic open, I just saw there's a question in the chat about insurance companies and billing, and I just want to answer that because I should have touched on it. One of the things that's come up a lot in the question of vaccine is, well, do you have to bill insurance in order to get your insurance, either the individual's insurance or otherwise look to insurance for reimbursement? Or the answer is, generally, no. The vaccine is 100% federally funded. These pop-up facilities are not required to go and seek insurance reimbursement, and so we will fully reimburse those costs. The only exception would be those entities that normally bill for healthcare. So if a vaccine is being distributed in a hospital or in a doctor's office or in a primary medical facility, they are expected to follow their normal billing processes. Just because the federal government's in town doesn't mean they can stop going through those processes. But for what you all are focused on generally in terms of these pop-up vaccine centers, your costs, you're not normally billing your time to insurance. And so therefore we don't expect you to do that in this scenario.
Okay. Keith, there was a second part to that first question I asked you, and it says, also, since this will be an ongoing endeavor, do we wait to apply for the PA or just keep submitting?
So we have not what we normally, good question. What we normally do is set a deadline 60 days or so after the declaration for all the work to be identified. We have not had any deadlines. We've not established any deadlines since the beginning of the pandemic. We will eventually, and just because there'll come a point where it's time to start getting those costs in. So you have the option, really, right? You have the option of submitting at a later point, and so before we set a deadline, or you can submit as you go. A lot of it's going to depend on when you're looking for that reimbursement. But I would stress what I said, and I know what was said earlier, is you got to keep your documentation and make sure you keep that well documented. And our experience is it can be harder when you're looking back 6 months, 12 months later at what you did to get that documentation in. So I would encourage you to at least keep it or submit as you go. But a lot of it depends on your timing for needing reimbursement.
All right, and there's a question that popped up here on the chat. It says, for Keith, last week's statement from FEMA regarding 100% cost share said that FEMA will be issuing an amended COVID-19 policy to implement the White House and directive. When do you anticipate the amended policy will be released?
Yeah, so we're in the final stages of getting that policy done. And just to be clear, the 100% cost share, that presidential memorandum is essentially self-implementing. We are giving guidance to our regions to start funding projects at 100% and to also start working the process to amend projects that were already approved at 75 and turn them into 100. So that part we're working on. What is referred to here is that the presidential memorandum gave us the authority, directed us to pay for opening and operating costs for schools, for transit, for healthcare facilities, and other eligible applicants. And that means paying for PPE, for screening at facilities when folks come in every day, for cleaning and disinfection. We are issuing a policy on that. That eligibility, that increased eligibility, will be only from January 21st, 2020 and forward. That was specifically in the presidential memorandum. So it'll be moving forward, but we're going to get that policy out. I think very soon. We're in the final stages of getting that coordinated. So I'd expect to see it, probably not this week, but ideally next week you'll see that.
All right, Keith, I'm going to keep shooting at you because obviously the money must be important to people, not only the vaccination operational component, but the money part. So here's the next question for you, Keith. On reimbursement, does FEMA supply the state with X amount of dollars to administer the vaccines based on the state plan? Then the state distributes the money down to the local level. In other words, is there a pass-through at the state level?
All of our funding is technically a pass-through. All of our funding is to a grantee, which is the state, and then it's passed through. Now, states are taking different approaches in terms of how they're formulating their requests. Some states, many states actually, because they're looking to move quickly, have said, hey, let's take a percentage of our population, how many people we think might be able to get vaccinated in the next 90 days. We're looking at the next 90-day window, and then we'll provide more funding if we need to after that. And we're saying, okay, based on this population, based on an assumption of how many sites we're going to need, we're providing funding to the state, and then the states are going to pass that down. Some other states are doing it where they're taking some funding at the state level, but they're also moving individual requests from localities. And so California, for example, is doing about a 2/3, 1/3 split, where some 2/3 the funding at a state level, but also allowing for some projects to come from the local level. So a lot of this is because we're moving really quickly, moving really fast. Now, that thing that's approved is not the limit. If there are costs that are eligible, they're associated with vaccine distribution, it can always be submitted and approved at a later point. That's just what we're doing with the states on our initial funding structure. So again, my best advice on vaccine is get in touch with your state emergency management officials, find out what their strategy is and how your reimbursement will fit into that, and we'll make sure we get it worked out.
Very good. I have one more here. We have multiple EMS agencies, both public and private, assisting public health with vaccination efforts. Obviously, the costs vary from agency to agency. Will that matter if public health applies for the PA? And then go ahead and answer that, and I'm going to wrap up after you get done answering that.
Yeah, so the question, it'll depend on who the applicant is, right? If in the applicant's the public health entity, and then they are contracting and or have agreements with either public or private entities, both of those are acceptable, or they can contract with a private entity, they can have agreement with a public entity. And the cost can vary. Obviously, the costs have to be reasonable, but individual contracts or agreements with different entities can have different costs associated with the circumstances. So again, the key thing is going to be documenting who you worked with, what agreements were in place, what the conditions of those agreements were, how you came to the costs associated with them, and that they're reasonable. And then the documentation can be submitted and the cost reimbursed from there. So we're really trying to be flexible, knowing that there's a variety of different methods in which this is going to be done and coordinated. At the end of the day, reasonable eligible costs, we'll find a way to work with you all, with the states, and get those costs in the system and get them reimbursed.
Very good. And that person asked, can you please share your contact information?
Sure. So Keith Turi is my name. My email is, like all folks at FEMA, is keith.turi@fema.dhs.gov. That's the best way to get me.
Turi is T-U-R-I, you're correct.
T-U-R-I. Keith.Turi, T-U-R-I, @fema.dhs.gov.
Wonderful. Brian, do you want to share your contact information if anybody has any questions?
Absolutely. It's Brian Fennessy, B-R-I-A-N, F like Frank, E-N-N-E-S-S-Y, @ocfa.org.
All right, very good. Well, this was fabulous information today, phenomenal information. And as I said earlier, there's only one way we're going to truly get out of this. There's a reason why there's no more smallpox and no more polio. We have vaccinated our ways out of those terrible diseases, and hopefully we'll be through this one day also. Tonya, I'll put you on the spot. Are there any last comments from you?
Last comment. Thank you all very much for joining, and look forward to the opportunity to see folks in the future. Always good to see you, Brian. Thank you. Thanks, Chief.
Thank you. Thank you, Chief Hoover, Chief Fennessy, and thank you, Keith.
Thank you.
This wraps up our webinar for today, and we hope that you all stay safe. Thank you so much.